begin the recording. So thank you everybody for joining. My name is Nina and I am the founder and CEO of Pre-Health Shadowing, and I'm excited to welcome you back for another virtual shadowing session with Pre-Health Shadowing. Pre-Health Shadowing is a student-led, women-led nonprofit organization focused on creating flexible and accessible learning opportunities for students everywhere. Thank you for joining us today. I'm going to go through a quick startup presentation before we get started. We do have closed captioning available to accommodate students of all abilities and needs. If you have any ideas about how we can be more accessible, please email us at info@prehealthshadowing.com. Additionally, I encourage everybody, if you're interested in joining us for more virtual shadowing sessions, we host them all the time. If you want to make sure to never miss a session, you can join our email list on the Pre-Health Shadowing website, and you can save us as a contact. Here's a little tip. If you save us as a contact, we will bypass the junk folder, bypass the spam folder, and the promotions folder, and you'll go straight to the inbox where you can see it in real time. So I encourage everyone to do that if you're interested in participating in more virtual shadowing sessions. If you're interested in staying in the loop, we do have, sorry about that. If you are interested in staying in the loop, we do have an Instagram page and other social media. You can follow us on Instagram, TikTok, and Facebook at Pre-Health Shadowing to learn more about our opportunities, our volunteering events, as well as just events for scholarships, awards. We do host various partnerships. So if you're interested in being a part of that, I encourage you to check it out. We are an international program where we host students from all over the world. I'm interested in learning where you are calling from today. Go ahead and throw it in the chat. I am currently calling from California. I'm in SoCal in the United States. If you are interested in being a part of the Pre-Health Shadowing team, we are currently recruiting. And so if you're interested, you have no plans over summer, you're looking to get some volunteering, some leadership experience, connecting with some folks, I definitely encourage you to check out the Pre-Health Shadowing website. We have opportunities to be student volunteers as well as leadership teams. And so check out the website. I will be sticking around at the end of the virtual shadowing session today. If anybody has any questions about joining the Pre-Health Shadowing team, either as a volunteer or as a team member. We do have lots of various leadership roles that I'd like to highlight that go beyond the just general organizational items. They're not necessarily health related. So if you have any passions, whether it be in technology, whether you're interested in going into research and looking into grants, fundraising, if you're into media, videography, editing, diversity and inclusion, writing, we do have an editorials department, all of these various items. I encourage you to check it out. Here's a little glimpse about what our application looks like. So I encourage you to look at that. Additionally, if you are a high school student, we do have a high school training program titled HTP, where we are working to establish pre-health shadowing as a club on various high school campuses across the US. If you're interested in either starting a club on your campus or being a PHS ambassador to help other students start clubs on their campuses, I definitely encourage you to check that out. If you're looking to get published, Pre-Health Shadowing does host members of the Pre-Health Shadowing community to post their articles, reflections, reviews, and success stories. So if you're interested in learning more about that, you can check out our blog submissions link down below. And we look forward to reading your pieces. Additionally, Pre-Health Shadowing is a student-led nonprofit organization when we run solely off the time and energy and donations of our volunteers. If you are financially able to donate at this time, we encourage you to scan this QR code, go to our donation page, and to open up more opportunities for students in the future. Throughout the duration of today's session, I encourage you to type your questions in the chat. Our co-hosts will ask them during the Q&A portion of today's virtual shadowing session. Please take good notes because at the end, there will be a post-shadowing assessment that will be available that you'll be able to take to earn a digital certificate that verifies your virtual shadowing hours with pre-health shadowing. If you can, please turn your cameras on. This makes it a fun experience. It's a lot better talking to a bunch of faces than a bunch of little boxes on the screen. So if you are able, please turn on your camera. We'd love to see you. Without further ado, I would like to welcome to you our professional for today. Thank you so much for joining us, Dr. Gray.
Hey, you're welcome. Thanks for inviting me to join, and thanks for everybody logging on for whatever time of the day or night it is, wherever they are. Sounds like it's 4 o'clock in California, and I'm at 7 o'clock here. I get the sun setting in my face, so we'll get a cool little glow. It's better than the ring light that everybody has. So let's move ahead, and unless anybody has any questions, we can just start rolling here. So what we're going to do is I'll just start talking. If anybody has questions or wants to break in, ask anything in the chat, please do. And Nina or Natalie, stop me and make sure that I listen there, or else I just end up just rambling continuously. You guys have probably all seen a lot of Zoom in the past 2 years. I've given a lot of talks with Zoom. It is crazy boring sometimes. So I'm going to try to give a little intro to what my life is like and what my journey was to get here. And then we can go into either doing a couple case presentations. I have a bunch of little short 2-minute videos of surgery that I can show you guys of different things I do. And then we can do kind of question and answer at the end. So that's kind of what we have planned for this little session. Any questions before we start? All right, cool. Well, what I'm going to do is share my screen and figure out where my presentation is. There we go. All right. So I am Brian. I'm a pediatric general surgeon from Indianapolis, Indiana. I work at Riley Hospital for Children, which is the children's hospital associated with Indiana University School of Medicine. And as you can see, I do a lot of different things in my day. Let's put it through here. So first, my disclosures. I have no financial disclosures. I'm not making any money from this, or nothing I'm going to say tonight in this presentation has anything to do with something that would be paid other than just my regular job. I'm a graduate of the University of Notre Dame in 2002, go Irish. So you can see I'm kind of a lot further out from undergrad than you guys are. And then lots of training since then. I'll talk about all the time that goes into all those things. I went to Vanderbilt in Nashville, Tennessee for my MD degree. And then I was a general surgery resident at University of Michigan. And then I finished up my training at Indiana University at Riley Hospital for my pediatric surgery. And I love my job. We'll talk about that a little bit here. So what do I do all day? So I think it's helpful to figure out what, for students you're thinking about going into some kind of health career. So what do I do? Well, number one, I walk around. I talk to a lot of people. I talk to nurses, I talk to residents, medical students. I talk to the patients, talk to our nurse practitioners, talk to colleagues, and we try to listen to them as well. So I talk to people, I listen to them, I teach, I do a lot of teaching. And when you're in a academic hospital, you see all sorts of learners at every level. So we have medical students, we have undergrad shadowers, we have, residents who are the first levels of being a doctor. So they're doctor, still in training, so that's the residents, and an intern is like a first-year doctor. You guys have probably heard that before, but some people might not have. And I was confused about that in my time when I was about your age, your level. And then we have fellows who are fully trained surgeons that are learning more about pediatric surgery. And then who else do we have? We have all sorts of nursing students, a lot of teaching. A lot of teaching goes on at the hospital. I look at the patients, I think about them, think, okay, what's going on? What can we do to help these people out? And then I do operations. And finally, I get to do some research. So when I break down my day, it ends up being about 60% operating in the hospital, doing consultations, about 15% in the clinic where I'm seeing patients either before or after surgery, or hopefully people that don't need surgery. I do research, which I do clinical research about 15% of the time, let's say. And then about 15% of the time, I'm exclusively educating, doing lectures, talking with our trainees, and trying to mentor people along the way. And then about 10% of the time is kind of administrative. That's doing progress notes, that's doing some of the research work, that's, like figuring out where the bathroom is, all those little things that you got to do. And so it's about 115% of the time is all good times. So my job is about somewhere between a 50 to 80 hour a week job, and we're earning and burning the whole time. It's great fun. So what are my jobs I actually get to do when I'm at the hospital? So I'm a pediatric surgeon. I'll talk about that a little bit more in a second. So basically a surgeon who operates on babies, older kids, all sorts of people. I'll show you more about that. I'm the Surgical Director of ECMO at our hospital. So I don't know if anybody's ever heard of ECMO before. It'd be interesting if people raise hand in the chat if you know what ECMO is. But ECMO stands for extracorporeal membrane oxygenation. So basically it means the support of someone's heart and lungs outside of the body. So when you have a patient come into the hospital and they can't be sustained on the highest ventilator settings we have and the highest blood pressure medications, we can put them on heart-lung bypass, where we literally take their blood out of their body, put it through a special pump and a special machine that puts oxygen in and takes carbon dioxide out, and then puts blood back in the body. It's really neat, really cool, and it's kind of the highest level of care you can give a person. And so I'm the surgical director of ECMO at our hospital. I actually did a 2-year research training fellowship for that. And then I'm also our pediatric surgery fellowship program director. So I get to help mold our fellows into fully trained pediatric surgeons and a clinical researcher, and some of the side time that I have. And I like to do research about ECMO. I do research about neonatal conditions, babies born with things that are not in the right place, and how do we figure out how better to diagnose them and treat them. And I do some research in education and wellness. And let's see what else I do. I'm the general surgery resident wellness champion here at Indiana University. So I do work with our residents and trainees and try to figure out how we can engender wellness in those people and help make them happy trainees and not just miserable people. So we work hard at that. And I'm a husband and a father, and those are 2 really important jobs I like to spend a lot of time doing as well. So those are all the jobs that I have. Probably have more, but I can't remember right now. And let's talk about what I do on a daily basis as far as what kind of patients I take care of, because this is the best part. This is the most fun. So I do pediatric general surgery, and what's that involves is a big question. So first I want you to think about, have you ever had an operation when you were a kid? So you ever had some kind of surgery when you were a kid? Chances are it was by a pediatric general surgeon. Basically, we do everything that's not the bones, the brains, and the heart, and like the tonsils. And so just about everything else, that's what me and my friends do. So we operate in the chest. We operate on the lungs, the esophagus, the chest wall. This afternoon, I popped in the OR, and one of my partners was taking out a lung malformation in this little 3-month-old baby. It was really neat, really cool. I can show you a video of what that looks like a little bit with one of my operations. So we operate on things in the chest. We operate on the abdomen. So stomach, liver, gallbladder, intestines, kidneys, tumors, hernias. So that includes the appendix. So if anybody's ever had their appendix out, that's what I do. That's one of the most common things we do in our job is taking out the appendix. Those things keep getting infected, and we don't really know why. Interestingly enough, appendicitis is almost unheard of in sub-Saharan Africa. So that's a little interesting, little mind scratcher for you. But they have other endemic surgical illnesses that we don't really see here, which is really interesting. A lot of kidney tumors, actually. I operate in the extremities, so arms and legs, lumps or bumps, extra fingers or toes. I'm doing some ingrown toenail surgery later this week. So all sorts of different fun things that you might have lumps or bumps that orthopedic surgeons don't really care about. We take care of trauma. So pediatric general surgeons are the trauma doctors at children's hospitals. So when I'm on call, I'm in the hospital on call overnight, taking care of any trauma that comes in. Just 2 weeks ago, we had a little 4-year-old guy who got run over by a truck and totally crushed his chest. And we really thought he was going to die as soon as he came in, but we actually put him on ECMO support, which I mentioned to you a little bit ago, because his lungs were so crushed. We were able to give his body oxygen, take away the carbon dioxide with our pump, and he actually came off ECMO support just a couple of days ago, and we're pretty sure he's going to live. So it's pretty exciting stuff what you can do. But you know, a lot of times there's cuts, there's dog bites to the face or arms, there's crashes and blunt injuries. We see some penetrating injuries, so some guns and knives, things like that. So pretty exciting at times, boring other times. We do critical care, so we take care of vascular access. Meaning if somebody's got to put something in a vein or an artery, we're the last ones to get called to do it, because we can get you an IV somewhere. ECMO, as I mentioned before. What else we do? So we do neck surgery. We take care of thyroids and cysts in the neck and the skin. One of the most fun things is butt pus, leg pus, all sorts of pus. It smells bad, and it's really neat. And then we can take care of scars and other skin conditions. What else? And then who do I take care of is kind of the next question. we take care of little babies in the womb. So we do prenatal diagnosis, and some pediatric surgeons do surgery on babies in the womb. We're going to be starting to do that at our hospital within the next year. So that's pretty exciting. We take care of teeny little babies. I just saw a little baby today that weighs about 500 grams. So that's half a kilo. And if you think of a kilo is what, 2.2 pounds. So so a baby look like this, maybe it weighs about a pound and just fits in the palm of your hand. And sometimes you have to do those operations on those. Like big are 100 pounds in one tube, and some are 1 pound. And so it's really neat to take care of. All right, my Zoom crashed. Are we back at it?
We are. You are back.
Sorry about that. I don't know what happened, but we'll be back. Let's do it again.
No worries.
Okay, so we had a crash Zoom. Cool to share screen again.
Mm-hmm.
Awesome. Let's do that. Let me see. Make sure I'm okay. Let's go back to our Zoom. Computers, you can't trust them.
No worries. I'll take this time. If anybody is interested in applying for the pre-health shadowing team, I encourage you to check out our website. It is in the chat, and I'll go ahead and throw it back up there. So yeah. All right, back to you, Dr. Gray.
Great, thank you. And sorry for that brief little delay there. So the question, next question I would have if I was in your shoes is, okay, what's this training like? How long does it actually take to get through all this medical training to get to the point where you get to do these cool operations on little babies? So for me, and this is me, because everybody's different, I did 4 years of college. So 4 years of college, and then I went straight through to med school. Back when I was in med school, people didn't do gap years. Gap year was something if you just like wanted to do the Peace Corps for a year, you would do a gap year. But as I understand it, all the undergrads I work with, it's becoming more and more common of a thing to do. And the thing I say about gap years is if you're going to do one, just do one that you really want to do because you want to do it, not because you necessarily need it for your application or anything like that. You know, go find something that you want to do and you want to either help make yourself a better person or make the world a better place. And then if you do that, when you get your med school interviews, then you're going to be able to talk about all that stuff all day long, and people are really going to see your passion and really enjoy what they see when they talk to you and they in their conversation with you to hear what kind of a person you become because of that gap year. I would think it'd be really boring to just do a year where I sat in a doctor's office like scribing all year long, but that's just me as a complete editorial. I'll say that. So med school, 4 years. I did an extra year. Actually, I took an extra research year during med school to kind of figure out what kind of research I was interested in and if I wanted to do academic medicine or kind of more private practice medicine. And I really liked the research stuff I did. So I decided to do an extra year and go into academics. So then I decided after med school that I wanted to go into general surgery. So I matched into a general surgery residency program and ended up doing 5 years of general surgery with another 2 years of research in the middle of it. And not all general surgery residencies have research that is cooked into the residency, but a lot of the academic ones do. So because it's a fact that's not the greatest fact, but if you want to be competitive for some of the more competitive residency programs, then you need to do 1 or 2 year research and really dive into something that's going to help make you an attractive candidate, but also do something that's going to really round you out as a physician, whatever you're going to be. So for me, I did a research fellowship for 2 years at ECMO. So I did surgery on pigs and sheep and was researching new ways to take care of babies with ECMO. And it was really fun, really neat. And it helped to make me a more rounded out surgeon, help to get the job I have right now. And it also helped me to get a fellowship spot. So then I ended up doing fellowship for 2 years after that. So when I get the whole tally of all the years, grand total, 18 years from the day I finished high school till the day I got a real job. And that was about 6 years ago at this point. So, so that's the kind of pathway it takes to get to somewhere like I am today. Everybody has different paths and different ways they go about it, but that's a little bit about me and where I'm at. So I can cover some of this advice later. You guys will if we don't cover the advice, I actually asked some of the medical students and residents I work with for advice for you guys, and they gave some good ones, but I figured we might cover that in the Q&A. If we don't, I can tell you about that later. So we have two different things we could do now. I have a bunch of surgery videos, or I have a couple of case presentations, which I have kind of prepared for kind of classic general surgery things or pediatric surgery things. What do you guys want to do? What do you think would work better? Any thoughts in the chat? Both, awesome. All right, how about I'll do a warm-up surgery video, a couple of videos, and maybe we'll do some cases, or one case or more, because we have until we have another 20 minutes or so before we want to do some question and answer. So let's do some videos. So one of the things I do is a lot of minimally invasive surgery.
Alrighty, I mean, it looks like we've dropped again, so I'll go ahead. I'm gonna put out a quick poll while we wait. And feel free to answer this poll.
Back to the poll. Okay, good. I get kicked off again. My Zoom is acting wonky, but you guys can take the poll.
No worries. Yeah, take your time. Feel free to answer this poll. This is going to be just generally questions, where you're calling from, where you are in your education, what you're interested in, and your relationship with pre-op shadowing. Is this your first time? Are you on our volunteer team? Are you interested in getting opportunities?
All right, so once you guys do that, I can share again and we'll see if this will work.
Okay, go for it.
Okay, thank you. Let's see. Okay, we're gonna go to, okay, this is a fun operation. This is called a lobectomy. You guys see some lungs here?
Yeah.
Perfect. So this is a baby who's got a lung malformation. So this is using a small 3 millimeter wide instrument to dissect around the pulmonary artery. If you make a hole in this artery, you're going to see a ton of blood come out real fast, and the child might not do well. So we take a lot of care dissecting around these vessels. So we've actually now divided the artery already, and this is now dissecting around the bronchus right here. So this is getting around the bronchus with our instrument. So this is a piece of space, about the size of a couple of golf balls stacked on top of each other. We're doing this operation in. So we're dissecting around the bronchus here, and then we're going to come in and dissect out the other side of the bronchus here, and then we have a pulmonary vein right here. Pulmonary vein is taking blood directly back to the heart, and again, if we get into that, there'll be a lot of blood that comes out. So this is now putting a surgical stapler in, and we're going to staple directly across the bronchus. Hold the stapler down, and we'll fire it here.
Dr. Gray, is there a video playing, or is this an image?
There is a video playing. Is it not playing for you?
Not playing on our end, but we do see the image of the video. We just don't, it's not moving. I wonder.
Let's see if I can make it one for a video play, because you just saw the image. Okay. So what I'm going to do is, anything playing right now?
Nope.
Nope. Okay. So that video is not going to work. I may just have to do some presentations or some of the case presentations, because the internet says it's not going fast enough, unfortunately.
No worries.
So let me just get one. I'll try to play one other video and see what happens. I'm going to try to stop share. I'm going to try to share one more time. Try another video. We always can pivot if we need to. Let's see. there. Okay, we'll try a different video here. We'll see how this goes. Now tell me, Nina, if you see, do you see a video playing or do you see a picture?
No, we still just see the picture.
Oh my gosh. Okay. So we're just going to go through some case presentation then. And that'll be a little bit easier if we don't get kicked off.
Sounds good. Thanks for being flexible.
Oh, no problem. Sorry about the internet issues we're having here. All right. So surgery videos, total failure, but now let's pivot. So we're going to look at this. Can you see my chest X-ray? It's a chest X-ray there.
Mm-hmm.
Perfect. Okay. So that's what we want to see. All right. So we have a chest X-ray, and let's talk about the X-ray first. So I'll tell you how I read a chest X-ray, and then I'll help look at some of the images we're going to look at in the next part. So first thing I look at is there's a bunch of different ways you can do this, but I like to look from the outside in and to see if there's anything foreign there. So I look around and I see, okay, do we see any IVs? Do we see any lines? Do we see an endotracheal tube? And this one's completely clear. And then the next thing I look at is the outside. Okay, let's look at the very outside. Do I see any fractures in these bones, in the scapula, and the clavicles? No fractures here. I look to see if the spine is straight. So I looked at the bones on the outside. Now I'm going to look at the edges of the lungs. So I see a lung here. I want to see if the lungs go all the way up to the chest wall. So I see, yep, lungs are going all the way to the chest wall. No pneumothorax. I look at the lungs themselves. Do they look clear? Do I see any masses? And then I look at the heart. And I see, do we have a good cardiac border? Does the heart look big? Does it look small? Is it shifted? So this is kind of what we would look at for our chest X-ray. And then I see in the middle here, the trachea looks just fine. And then have an abdominal X-ray. So the abdominal X-ray, similar things. I'm going to look at it. We'll look at the bones first. We look at the hips. We look great there. We look at the spine. That looks all good. And then we're going to see what the bowel gas pattern looks like. This one I can see there's this coming over here. This is the large intestine with some stool in it. I see large intestine over here with some stool, and then the small bowel in the middle looks fine. So those are normal X-rays. The other thing we look at is I see, it tells me it's a supine film, so the patient's lying down, and this is the right side as opposed to the left. All right, so let's look at the first patient here. I'm going to talk about some babies. So the first patient is a full-term infant who has a normal exam. And if you have, and some of these things will come to some question points where you can go ahead and put some answers in the chat if you feel like it. Try to get a little interactive here. So normal full-term infant, normal exam. The baby spits up their first feed. Okay. Spits up their second feed. Oh, what's going on? Then they spit up their third feed. Something's definitely going on. And nurse calls our team. So nurse calls the doctors, calls the pediatrics team, says, hey, this baby keeps spitting up. What's going on? So what are we going to do? And you have any ideas about what you do with this infant who keeps spitting up?
I'll go ahead and read what we got in the chat for those who are watching this asynchronously. We have some folks saying X-ray, lactation consult, swallow test, check airway, check throat for obstructions, and physical exams. That's what we got so far. If you're watching this asynchronously, feel free to think about this on your end as well, what your first steps would be.
Yes, perfect. I'm sorry about getting kicked off once again. This is killer. Okay, we'll share our screen again. We're back. Sorry about that delay once again. Let's do it. Okay, so we're back at it. So we're going to ask, what should we do with this baby here? And first things first, whenever I talk to residents and students, I say, first things first, we got to go see the baby. So we go look at the baby, and here the baby is. Can you guys see this baby? Let's see.
We're
Not
still on your first slide.
All right, we're gonna try to share again here. Okay. So now I'm back on here sharing. You guys see presentation again?
Yeah, we see the presentation. We're on the first slide.
The first slide, for some reason. So what I'm gonna do is I'm gonna stop sharing. I'm gonna exile the presentation and bring it back up because it's not playing ball right now.
What advice would you give to like students and undergraduate currently for if they're looking into going in something medical related? Like what advice that you wish you had, I guess, at this time?
Yeah, it's a really great question. And so the whole idea is, you do differently. What should you do? One of the biggest things is just find what you're passionate about and go do it in undergrad. So you don't have to just do a pre-med major, and you don't have to just do research in a basic science lab. You should really just do anything you want to do. If you think that you want to go into medicine, we need people who are doctors who have all sorts of different skills and things they're good at and things that they want to bring to the world. So find something you're passionate about and go do it. And that could be your major in school. That could be whatever kind of things you want to do from an extracurricular standpoint, and don't feel tied down to be like a pre-med person. Just go find something, go do it well. And then you can hone in your skills to be a very subspecialized person down the road. I'm sure some of those other advice points will come out.
You mentioned earlier that you work anywhere from 50 to 80 hours a week. Can you talk a little bit about how you can integrate having your own personal life alongside a career and kind of like your perspective on that?
That's a great question. So some weeks I'm working my tail off and taking a lot of call. Some weeks it's less call and I have more free time. I think that it's certainly possible to go into surgery and have a good work-life balance. Depends on how, or if it's especially where
All right, it looks like we dropped out again. I'll utilize this opportunity to mention here, if anybody has any questions for Dr. Gray, feel free to throw them in the chat, and hopefully we can get to them during the Q&A portion of today's session.
Could you post the poll again? I had it partially filled out and then it went away.
Yeah,
I can. Oh, I might not be able to. Let's see.
That we're back again. The internet is really killing me here. A lot of gap years. That's awesome.
Yeah, we got a lot of folks. Also, if you're interested in supporting PHS, I can mention again, you can volunteer with us. But Dr. Gray, it looks like you're back, so go ahead.
Back, totally. So I was answering the question about the time commitment. Time commitment is really a better way to say it's kind of what you want to make of it. So if you want to go into surgery, you should do surgery. If you think, well, I don't really know if I want to do surgery because of the time commitment or something else, then you need to watch the people who are doing it. You need to look at the surgeons you see, go shadow people in surgery, shadow people in dermatology, shadow all over the place, so you can get a good idea of just what people's lives are like. So then you can make that informed decision of what you want to do with your life when you're out of everything. And you shouldn't just look at the residents and what they're doing, because if you look at surgical trainees or medical trainees, you see just one little snippet of their life. What you really want to see is what is their life after that, and how you can fashion that towards your life. So hope that kind of answers the question. So it doesn't always have to be 80 hours a week. It doesn't always have to be 30 hours a week. It's usually in the middle, and then you find out how you want to roll with your life. All right, so I see that you've got the surgery question there. And I'll also say this too, I'm very protective of time with my family. So when I'm with my family, I'm there. I'm not trying to answer emails. I'm not trying to do other things. So I make sure I spend that time and make sure I get all my vacations in. That is for sure. All right, we have what's the kind of favorite kind of operation, or favorite kind of case. I was trying to show you guys a really cool lung operation, but it didn't work at all. No, I love doing, my favorite type is thoracoscopic surgery. So if you can operate in somebody's chest, you can take out a mass out of their lung, you can take a little kid who's got a tumor and you can remove it and they're cancer free. Those are really great things that you can do, and we can all do, and you can train on those things, and it's great. And lung surgery is wonderful. You get this big chest cavity to work in, and it's just really fun. I'll say that. So that's kind of my favorite operation. And also just like seeing patients get better. So if you can, what's one of the great parts about surgery, if you see a patient who they have a problem that you look at them and you say, I can fix that, or at least our team can fix that. We can all get together, figure out the best treatment for the patient, and go in there, do an operation, and they feel better afterwards. They don't feel better right away because you're in pain a little bit, but then they feel better down the road. And that's one of the most rewarding parts about surgery, is that you can do that and you see the instantaneous result of what's going on. And then kind of the next question here from Sonia is, what's the hardest part? And the hardest part is when it doesn't go right. So when you have a complication, so you have a patient who entrusts themselves to you, or a family who entrusts themselves to you, or their child to you, and it doesn't go right, because complications happen to everyone. And when things don't go right, it's really sad. It's disappointing. It keeps you up at night. It can really eat at you. And so you have to find outlets to help to right the ship after that if you have complications, and bring yourself back to center. So let's see, what was the next question?
So sorry, I was gonna. So yeah, we have. Why did you choose the field of pediatric surgery?
Oh, because it's awesome. So I was showing you guys all the different operations. So you got to figure out when you're in medical school, because you guys will all be there someday. If you're not there already, it's number one is what are you interested in doing all day long? Are you interested in being in a hospital and doing operations, or being in a hospital and rounding on the wards and seeing complex medical patients? Are you interested in going to the clinic? Are you interested in doing research? There's a lot of different things. You figure that out, and then you got to figure out, okay, do I want to do pediatric or adult size patients? You can do med peds, where you do some of both, which is really cool as well. And that's kind of the more academic form of family practice. So you can do those as well. I like surgery because it was active. You get up early in the morning, you run around all day, you talk to a lot of different people, you see a lot of different patients. You get to affect change with your hands and with technology, which is really cool. You can think about innovation as well. And then pediatric surgery is fun because of just the kids are great. The parents the parents are very appreciative of what you do. Sometimes parents turn wacko, and they get really stressed out because of what you do, what's happening with their kid, but you can work with the families and help them through a really tough situation. And then the range of operations we get to do are really fun and great in pediatric surgery. So that's why I have really enjoyed that field. I also found out that when I was in residency training, it was the specialty I did a rotation in that I worked the hardest in, and I wanted to stay the longest. So I wanted to stay there from early in the morning to late at night, and I wanted to work really hard doing it. And I felt like I got something out of it every day. That's kind of a long answer.
Awesome. That's really great. Really great for active individuals. If you're interested in that, feel free to ask more questions. Emily asks, in your opinion, what is the most difficult part of practicing pediatric surgery?
So I'll go to a different answer from the one I did before. Is sometimes you do something that's really common. So think about something you do every day that you're like, okay, I wake up in the morning and I go brush my teeth, and I go do this every day. So you're really good at it. You're like an expert teeth brusher. But then there's some days where you have to do something that you only do once or twice a year, or maybe you've never done it before, but you kind of heard about it. That's how pediatric surgery is sometimes. So a lot of times I'm like doing an appendectomy, or I'm doing a hernia operation. And it's like, okay, I've done this a million times, and I can do it in my sleep if I needed to. Sometimes you're half asleep because it's the middle of the night taking out an appendix. But sometimes you have these operations that are things you've never done before, and nobody else has really either. And some people have done something like it, and you've kind of done something like it. but you have to figure out how to take care of that patient and how to do the right thing for them without being to do something you do every day. So like, for example, this Thursday, I have an operation where there's a 6-year-old girl who's got a lung tumor that's come back twice now, and it's really big. It takes almost her whole half of the chest, and we got to get it out, and we got to get it to negative margins, and it may be invading her heart. And so I'm working with one of our cardiac surgeons, and we're going to do a sternotomy. So we're going to open up her chest in the middle. We're going to remove this tumor. We might have to put her on cardiopulmonary bypass pump in order to bypass blood out of the heart, so we can take it out of the heart, reconstruct the heart. And we have to take off her diaphragm, reconstruct the diaphragm, maybe take out some ribs. And hopefully at the end, we've removed all the cancer. So that's something that doesn't happen all that often, and can be pretty challenging to just make a plan and think about how you do that. So that's one of the harder parts, is doing stuff you don't do and trying to do it well.
Wonderful. During your surgeries, Ibarra asks, do you work with any PAs? If so, what are their roles in the surgeries?
That's a great question. I think PA is a great job. So we have, in our operating rooms, we have PAs, we have NPs. It kind of depends on the hospital system and the state as far as they hire more one or the other. But I think that the advanced practice providers are great. They really help to expand what we can do, especially if we don't have a lot of extra resident or trainee care. So I'll say for me specifically, we have more NPs than PAs. So I work with more NPs, but we definitely have cardiac surgery PAs in our operating room suite. And so I think it's a really cool job that somebody can go and get the PA degree and do a really great healthcare job that's more specialized, where you're not doing all sorts of random things all day long like I do, and really make a difference.
So how did you decide to go into the specific specialty?
So I think that the biggest thing is, what do you want to do? Is like you figuring out, okay, what do I want to do all day long with my life? And that's how I figured out pediatric surgery. And that's ended up being where I'm at today.
Can you tell us a little bit about choosing the med school that you went to and kind of what you looked for?
Oh, that's a really good question. So choosing med school is really, it's multifactorial, right? It matters what's your MCAT score, what are your grades in college, and what kind of things have you done to help make yourself a competitive candidate or not. So you first of all see, okay, based on all these things that I put together, my whole resume, what kind of schools am I looking at? Am I looking at these ones over here, these ones over here? Am I looking at, MD, DO, PA type of schools? What do I set up for? And then what kind of life am I looking for? And then after that, you think, okay, where in the world do I want to live? So what region of the country do I want to look at? Am I open to any region? Am I open to the Caribbean? Am I open to both, like I said, like DO or MD schools? And then you just like cast a wide net. You start putting all your feelers out there. You put all your applications out, and then hopefully you start seeing the interviews roll in and have the opportunity to go interview at these places. And hopefully you guys will actually get to go interview places now that hopefully things with the pandemic are getting a little bit better. And so that's kind of how you pick maybe where you want to interview. Sort of, what's your application like? Where do you see yourself living? Where you're interested in living? If you want to try it out a little bit differently. And then important factors too is like, are you really interested in staying at your state school so that you can save money on all med school, because it can be really expensive.
Definitely.
Oh,
yeah. Sarah asks, as an MD, are you working side by side with DOs at the places that you work at?
Mm-hmm. Yeah, so it's different in every specialty how many DOs are involved and how many DOs you might encounter. One of my partners in our group right now is a DO. So I think that being a DO is a little bit of a harder road for people who want to be super subspecialized, just because of not anything against DOs, but it's against it's the stigma against DOs in a lot of academic hospitals. So I know a lot of DOs that are really well trained and they're great surgeons, and they're great physicians. They know they are super smart. They're good at their job. Doesn't matter if they're a DO or MD, but there's stigma against DOs at some academic institutions still. So it's a little bit harder to get your foot in the door And that's just something to know, but just because you go to a DO school doesn't mean that you can't do whatever you want after that with training and the job.
Sonia asks, are there any specific things you enjoy doing outside of medicine?
Oh yeah, most of it is hanging out with my family. I just did my 4-year-old goes through 3-year-old soccer game right before this. So when you get to be my age and you have a bunch of kids, it's like your majority of time outside of the hospital is just hanging out with the kids and your family in any way you can do that. I also like to smoke meat in my backyard, and I like to go out and hike and camp and get on my paddle boards when I can when it's not cold outside. So I like to be outside and make tasty meat and work on my bourbon collection.
That's really great. And, kind of a question that comes up in my brain is, this whole aspect of going into medicine and doing that whole family planning. Do you have any advice for individuals that are interested in having a family while also going into a field that's very demanding?
Oh, that's a great question. I would say number one, have some kind of plan is good. Number two, don't completely exclude certain specialties just because you do want to have a family. I think that there's been a long history of especially women being discouraged from going into surgical specialties because of the people, number one, like kind of keeping women out because they say that they can't spend the hours, they can't get the training, they're not tough enough. I think that's all crap. And so, and more, the world is switching to where if doesn't matter who you are, you can still do any of the specialties. It just means that you have to kind of plan out what you do. So my wife is not in medicine, but she works 40 hours a week. We have a full-time nanny who comes all week long, and we pay her lots of money, and she is awesome. She takes care of the children very well. But I don't have a job very, very purposely. I'm not staying home all day with the children because I'd probably go insane. But some people will say, hey, I want to work as a physician. I wouldn't want to do 2 days or 3 days a week, and the rest of the time I want to spend with my family. So that's also possible too. So it's really just planning. And I think that we're getting better in training as far as being able to allow people to have kids and have families. So it's been classically in residency. It's been really hard to have kids, whether or not you're the mother, father, and take time away from your training. And so what's been nice more recently is new rules to allow people more paternity and maternity time after having a baby, to allow people have a little bit more freedom with that. And also allowing people to still sit for their board exams after they have babies. So that's very possible. And I wouldn't let it hold you back from doing whatever specialty you like.
Wonderful. That's really great to hear, especially being a woman looking to go into medicine. It's always reassuring because it's definitely crossed my mind. We do have another question. Madison asks, what extracurriculars did you find most beneficial as an undergrad?
Okay, so that's a really great question. It's really whatever you want to do. Oh my gosh, there's so many things that are good. So I'll say this. I did a second major in Japanese language because I was just really interested in it. I liked it. I spent a summer in Japan. I talked about it all the time during my med school interviews. So that was really helpful. That made me, somebody who stood out a little bit. It made me somebody who could, talk about something different in my interviews. You need to make sure though, if you put on your application that you speak another language, that you have to be able to speak that language, because someone will test you. They'll start speaking to you in whatever language that you claim to speak. And if you can't do it, then you're kind of hosed. So make sure you can speak the language. I thought that was really beneficial. Just doing something totally different, totally foreign was great. I did some global health things. I was in student government a little bit in my college. I did a lot of different things, but keeping yourself busy, being a leader in different roles is really helpful. So like I mentioned before, really whatever you want to do is fine. You just got to go out and be successful at it and try to be a leader in whatever that is too, because they want to see that you've had leadership roles.
Quickly slip in, if you're looking for leadership roles, you can apply to pre-health shadowing team, and I'll pass it to Natalie.
We have someone asking, what qualities does a good doctor need, and what is the hardest part of medical school?
That's a great question. So I think that qualities you need to be patient, because there's going to be a lot of time where you are dealing with difficult situations. You need to be patient. You also need to be able to make decisions. You need to be a critical thinker. So that's one of the areas where we're choosing to do the hard things that are more difficult in kind of college and your time after that are very useful to becoming a good doctor, because you want to be able to get yourself in tough situations, figure out how to work your way out. Working with a team, more and more medicine is team related. And so you want to figure out, okay, how can I take care of this problem, not just me, but with all the people around me in a team. And so figuring out how to work in a team to get things done are good. The ability to just memorize everything rote is not as important anymore, because we have devices and we have the internet, so you don't have to memorize entire textbooks. I think that's not as important. It's more like your interactions with people and your ability to make decisions, and then in surgery, the ability to carry out those decisions. And while you might be a little bit scared about what might happen, you guys still just say, hey, we're going to do it and just take care of it. So those are some of the things that we look for as far as qualities that a good doctor might need. Also, having a little bit of ability to talk to people. So you're going to have patients who come from all walks of life. So you want to be somebody who can recognize that everyone has their own individual talents and their own individual benefit and worth as a person. Treat people well, and then help them do whatever they can to get better. So I think that those are some of the things we look forward to and look for in doctors. And so it's always hard to figure that out when you're, if you were applying to med school and I was on the applications committee, it's always hard to figure that out. But that's why you got to kind of put yourself forward, and hopefully people will see that in you. And then what's the hardest part of medical school? Probably getting in is the hardest part. Say that it's like once you get in, then it's studying and it's taking the exams. I think that step one, the USMLE step 1 and step 2 are probably the things people worry about the most, because anymore step 1 is pass fail, but the step 2 exam is not. So really the only thing that you have that's really going to be an objective comparison between you and a student at some other medical school for residency is what you do in your step 2 exam and that score you have. And so you need to get over a certain number for a lot of different specialties. They have all the different specialties have a different kind of base number they're looking at. And if you don't get over those numbers, you're going to have a hard time getting interviews. If you do get over that number, then it kind of opens those doors for you. So I'd say the hardest part about med school is the stress that goes into taking those board exams and doing really well with them.
Very interesting. Tanya wants to know, is it common for people to enter your field by doing a PEDS residency and then a surgical fellowship or something like that? And also, do you interact with your patients much, and what is that like?
It's a good question. So I've known a couple people who've done PEDS residencies first, and then they go into surgery. It's usually people who like pediatrics but haven't seen enough surgery before they choose to do pediatrics. And then when they get into pediatrics, they say, "Oh, I like the kids and I like these problems, but I want to be on the surgery fix it side." And so I've known a couple people have done a pediatric residency, but then how it works is that if you do a 3-year pediatric residency and you decide you want to do surgery, you have to then go do a 5-year surgery residency after that. And then you can do your fellowship. Different specialties are a little bit different. So say you want to do pediatric emergency medicine, you could do pediatrics first and then a fellowship in emergency medicine. You could do it the opposite way, where you do emergency medicine first and then a fellowship in pediatrics, or they even had combined residencies now where you can do both. So that's a different way to do it. Most pediatric residencies or pediatric subspecialties, you go through pediatrics first. So you do a pediatric residency and then you do the subspecialty after that. The surgical ones are different, where most people will do the general surgical ones, whether it's neurosurgery or cardiac surgery or pediatric or kind of general surgery for us. And then you do the subspecialty after that. So that's kind of about getting into those fields. And then interactions with patients. Yeah, patients are the best part. It's I'll say another hard part about pediatric surgery is a lot of our patients hate us because we're, little kids are scared of the people who come in the scrubs who bring the pain. And we do bring the pain, but we have to believe that we're going to make them better in the end. So so we do interact with our patients, but sometimes it's a little bit challenging sometimes. Just dealing with the patients when they're in pain and when they don't like us. It's great working with the teenagers who you can really interact with and form a relationship with. Little kids, you can do that, and so it's fun to do it. And sometimes in my field, we get to make longitudinal relationships with patients. So we get to see patient early on, and we get to follow them for years over time, even when they're a baby on to when they're an older kid. And that's really fun because you get to know the families, you get to know the kids, and then sometimes they send you Christmas cards and things like that.
Along the lines of seeing patients, how do you handle difficult parents, whether it be they don't agree with, the procedure you're suggesting, or they're just kind of crazy with stress?
That's a great question. There are certain people that can do pediatric specialties and certain that can't. If you can't deal with stressed out parents, then you probably can't do a pediatric specialty. So that's something that it's good to figure out early on in your time. People get a lot of stress especially when their kids are sick. And so number one is just being patient. So you have to be able to talk to somebody and be patient with them. You have to meet them on their level and figure out what their stressors are and what they're worried about. And if somebody wants to yell, if they're angry, you just sit there and let them yell at you. And then you ask them sort of, try to figure out why they're angry and what's going on and figure out how you can help them. Sometimes people, we'll say most of the times people are reasonable, and you can talk to them and figure out what's going to go on and make a plan and have a good relationship. Sometimes people are just completely crazy, and you just have to do whatever you can do to take care of the kid or the patient without can I say blowing a gasket at them. You don't want to ever yell at somebody. I get triggered a little bit when somebody accuses me of doing something I didn't, or accuses me of lying to them, and so I'll be firm with somebody when I need to, but try to be very reasonable all the time. It's a great question because it can be very challenging, especially in pediatrics.
Do you have to work with Child Protective Services a lot, or do you avoid that?
Oh, we have to all the time. Yeah, that's a great question. So in pediatric trauma, if we see a kid that comes in with a skull fracture or a fractured arm, fractured leg, or sometimes abdominal injuries or chest injuries, we have to assess whether or not we assess what we see their injuries are, and we have to objectively record the injuries. And then Child Protective Services comes and does an assessment of the entire situation. They talk to the social worker, they talk to us, and they figure out if they think that the child is in a safe environment or not. And sometimes we're called upon in court in order to testify one way or another if we think that somebody has been abused or a child's been abused. So this can be really hard circumstances, especially when it means that somebody will have their child taken away, or when it means that somebody who shouldn't have a child is trying to get them back. And so those can be pretty challenging. And so your job as a physician is just to be as objective as possible. Take down all the information, record the data, make sure that you're objectively assessing the whole situation. And then if somebody asks you about it in court, then you just tell them what you found and don't lodge any opinions. But those can be difficult situations, particularly we have irate parents sometimes that don't know why they're getting spoken to by Child Protective Services.
Makes sense. Did you experience burnout? Do you know anyone who experienced burnout? And do you have any suggestions on how to avoid it, how to help with it?
Oh, that's a really good question too. So I've never been burnt all the way out, but I've definitely been at the end of a day or in the middle of a day where I'm like, man, I can't finish out. It's just enough to put one foot in front of the other sometimes when you really tired, you've had a lot of call or had a really, really tough patient situation or something like that. And so those are the circumstances where everybody has something like that. And the question is how do you kind of get through that? How do you get on the other side, and what kind of support resources do you have? So for me, it's really like kind of getting out of the hospital, going to talk to friends, family, just sitting and watching my kids play, doing something like that. It kind of helps me. Getting some sleep helps me. And different people have different reactions to all the little stressors. So sometimes it's like one big thing that can cause you to be pretty afraid. Sometimes it's a lot of little things. It's like death by a million paper cuts, where you're just getting like beat this way and that way all day long, and then eventually you're kind of done. But some days you're like, I can take on the world and have all the energy. So So burnout's like a great question, and it's really hard for us educators in surgery and in medicine to figure out how to best prevent burnout. So as a trainee or as a student, like, oh, what can I do to prevent burnout? And it's like, we don't know. Like, nobody knows really. There are lots of different ways we think are helpful. Some people benefit from counseling. Some people benefit from hiking. Some people benefit from cooking. So it's like, it's a very personal thing to figure out how you as a person are going to not get burnt out going through the stressors of medical training and the stressors after that. So I would say the best thing is to figure out what you can do to be as you as possible, because that's the hardest thing. Like, I feel like a part of getting burnt out is losing who you are, like losing yourself, because of not sleeping and stress and all that. So if you can figure out a way to find out who you are and get back to that, that's probably the best way to prevent burnout. And so I'm actually doing a research project with one of our residents this year. We're going to try to figure that out with our residents and try to do like a peer mentoring program to help residents like find their center and prevent burnout as much as possible. So stay tuned for that. Hopefully we'll publish that sometime.
Okay, we'd love to hear that. And that's also great advice. Emma wants to know, can you speak more about your other roles outside of surgery? You mentioned being a resident manager.
Yeah, so it's one of the great things that you could do in academics. So say if you were just a private hospital, your typical roles are, you're going to go operate, you're going to go to clinic, you might be a clinical program manager or something, but that's about it. In an academic hospital, I get to hang out with residents and students all the time. So I get to be an educator for our fellows. I work with our residents for our wellness program. So I help to engender wellness amongst the residents and work with them and figure out how we as educators and surgeons can do better for the residents. And then with the students, a lot of it is mentoring. So a lot of medical students want to figure out, okay, how can I get into surgery residency? What do I need to do? And so some of that's just advice, some of it's teaching, some of it's doing some research with them so that they can get things in their CV, and it helps both of us so they do research. So there's a lot of different things with that. And then with residency, kind of a similar thing. The residents have determined they want to do this specialty or that. So if they determine they want to go into pediatric surgery, somebody's going to come up to me and say, hey, how can I do this? What are the best ways I can make myself attractive for that specialty? So I have several residents I'm working with now as I'm trying to get them into ped surgeon. It's fairly competitive. It's about a 60% match rate in pediatric surgery fellowship. So of I think this year there's probably 75 or 80 people in the match, and there are like 45 programs. So 50 or 60% success rate to match once you already get to the point where you've like been very successful in residency. So it can be challenging. So it's good to have people to guide you through.
Is that something you like volunteered for, or does everyone in your department kind of have like that breakdown you gave of like, I do this much sort of like mentoring versus this much research versus like education?
That's a great question. It's different for everyone. So I really enjoy the mentoring and the education. And so I take on more of that. Everyone in the surgery department, everyone in any of the academic departments, they'll do different amounts of mentoring and education. But some people take on more than others, but everybody's got to do some. So it's just something everybody's doing part of it at least.
What is the craziest case that you have done in your career?
That's a good question. Craziest case. Well, sometimes you pull crazy things out of people's rectums that they put up there. So that's a crazy case. Sometimes I have a whole series of photographs of x-rays that are crazy things people put up. One guy kept putting softballs up his rectum and kept getting him stuck. And so this was a man. This is like a 6-year-old man when I was a resident. So not a child, but that was pretty crazy. We have, some of them are crazy where let's see, like crazy cases are pretty, I want to say, it's hard to remember each crazy one because there's so many that go together. I'll say that. Sometimes.
What about but like most memorable?
Most memorable. The most memorable ones are the really hard ones that you stress out a lot about, but then the kids do well. So I've had a couple of kids with congenital diaphragmatic hernia, where these babies are born with a hole in their diaphragm, and it ends up they have really small lungs and they have something called pulmonary hypertension. where the blood can't flow through their lungs to the heart very well, or from the heart to the lungs, sorry, opposite way. And it's a pretty high death rate when you have a really severe form of that. And so when you have a patient who has been born with that and then treated with ECMO support, as I mentioned earlier, when we put them on bypass, and then we fix the hole, get them off bypass, and then you see them come back in clinic and they're like smiling and running around. Those are like the really cool ones, and the families are usually really happy, and they are very appreciative of the whole healthcare team and what everybody's done. And so those are some of the really gratuitous ones that you feel great about afterwards. And so that very memorable ones. And then you have to see those patients every 6 months until they're like old and gray. So then you get to really know them.
Megan wants to know, did you ever consider PA school before med school, and why did you choose med school?
That's a great question. Funny enough, like I had no idea what a PA was when I was starting out. So if I think back to when I was applying to med school, it was like 2001 probably. And 2001, 2002, I was applying, and I had no idea what PA school was. And so I think it's a different world now where we have a lot more of advanced practice providers like PAs and NPs. And so, you can go straight out of college and go to PA school. You could go and get a degree as an anesthesia assistant, where you're kind of like a CRNA, but it's like the PA of the CRNA world. And so you can go do those jobs. And some of the differences is that you have a little bit more, I say it's a little bit more of like a 9-to-5 job as far as a PA or an NP. So say if you want to go to PA school and you have a lot of passions in your life that you don't want to get sucked up by going to work. That's a good thing. That's kind of a good role to go to PA school. So say you're going to work 40 hours a week. This is your time. You're not being pulled to like do extra call. You're not being pulled to do this or that. You're not getting any patients calling at night. Like I have this one dad who likes to text me at midnight because they don't sleep. So if there's ever a problem with his kid, like they just text me at midnight because he thinks that everybody else is awake. And so if you're a PA, you're not getting that. So you're not getting your life interrupted by the job outside of your 9-to-5 hours. So it's important. There are some PA jobs where you take call for like emergency cardiac surgery or something like that. So there are those jobs, but then you get compensated for it in the back end. As a PA, you get paid really well. The pay is probably not as much as being a physician, but it's well worth it for the amount of hours you work. And so there are a lot of benefits to it, and some of the drawbacks are that you're not kind of in charge. So if you're somebody who you want to be in charge of all aspects of patient care, of the care plan, then PAs don't typically do that. So you still have to answer, you have to run all the patients by a physician. You have to have a physician whose name is on the chart. So I think there are a lot of good parts about it. I really like working with PAs. I think I would be frustrated by not having the ultimate control in making the decisions and care for the patients. So that's differences. And then PAs don't typically do a lot of research. So if you're interested in research or research the part, some do education. They'll educate kind of PAs who are coming down through and going through PA school, but they don't do the research part either. That's a good question though, because it's now you can be a PA, you can be an anesthesia assistant. If you go through nursing school and work in ICUs for a few years, you could do a CRNA, you could do nurse practitioners. There are a lot of other different jobs that I wasn't even aware of when I was going through. Other questions or anything? I wish I could have shown you videos. I'll show videos and total bummer.
I mean, I think we're open to see if it works again. If not, we can ask more questions.
Yeah, let me give it a try. Let me pull up one of these guys here and see. Maybe it'll work. I've moved where I am in my little bonus room here, so maybe the internet works better. Just give me a second here. We're gonna try. All right, so I have a video I have here on my desktop. We're going to see if I can share it, if it actually works. We'll do one at a time. Okay. Can you guys see the video now? See the screen?
Yeah, we can see the screen.
All right, now I'm going to push play and we're going to cross our fingers.
Oh, there we go. It's working.
Sweet. Okay. So this is a operation for pectus excavatum, where this teenage boy's heart, or the heart is being squished by the sternum, basically. And so this you see here is a cryoablation probe. And so this probe going into the chest is freezing the intercostal nerves to minus 60 degrees centigrade. It freezes the nerve so the patient has almost no pain after surgery. That was just re-inflaming the lungs. And here we go to the opposite side. So we do the left side, then the right side. So here is the right. And then now we're actually making a space between the sternum and the heart here. So you see the heart down here, the sternum up here, we're making a space between those. Video still working? You're still good? Awesome. Good. So we're making a space between the heart and the sternum. And we can see the other lung actually peeking through there. And what we're going to do after this is put a bar underneath the sternum and pop the sternum up so that now the heart and lungs have a chance to expand in the chest. So you'll see the bar coming across here. So this is we're actually pushing down on the heart right now. You get a couple of arrhythmias from time to time, but it's pretty safe. So there's a little, like I say, a giant clamp that's going across. Make some space. And after that, we'll be pushing the bar across. There we go. So there's the bar going across. This is a stainless steel bar that goes under the chest. It goes in like a U, and then we flip it to where it looks like a rainbow. And then look at all the space we have here now. Oh, there goes. We're flipping it. Okay, bar's flipped. And so now this is the pre-picture. Sternum right on top of the heart. Now here's the post. Here's the sternum. Here's the heart. Look at all that space there. Isn't that gorgeous? All right, so that's a pectus operation. Should we try another one? Should we roll the dice?
Let's do it.
Okay, you
That
guys
was
are
awesome.
you guys are being very patient. You come to the OR someday, we're going to show you the whole thing. Let's do a, you guys want to see a torsed ovary? This one's a good one. Let's see. Okay, so my ovary case is there. All right, so we're gonna share this again. So this is a teenage girl who came in with pelvic pain, and we found that she had a torsed ovary. We could see over here on the right side. Is it moving? Do you see the video going? This is a giant ovarian cyst that we first opened up, and we're going to drain a bunch of fluid out. So this is in the belly. So giant ovarian cyst. And here's actually the ovary. See this purple thing in the bottom? That's her ovary that's full of blood. And this is probably the size of a basketball, this giant cyst. And so we're now detorsing it. So we're untwisting it. And then we have to remove the cyst wall off of the ovary. So there's the ovary at the top. This is a kind of pretty black looking ovary. Unfortunately, this ovary ended up dying, even though we untwisted it. It was just too far gone. But we saved it there, and we then did an ultrasound down the road to see. So we can see here's her uterus at the top, here's her fallopian tube, and here is where it was twisted off. And so now we've untwisted it there. So now this is using a sealing device to remove the cyst wall off of the ovary. And you see there's a bunch of blood clot inside of it because it was a big hemorrhagic cyst. So she bled into her ovary and then developed this big cyst, and then it twisted off the blood supply. So that's another thing that we get to do in my job is we do ovarian surgery too. So take care of that. So here's the big cyst almost all the way off. So as a resident, as we have our trainees and the residents, we get to train them how to do these procedures. We have a simulation lab. They go in the sim lab and they work on training on box trainers. So here's then the ovary untwisted. They do box trainers, and then we go in the operating room with them. Here's a normal ovary on the other side. What that look like? All right, that was good. We have one more time. You guys want to try another video? Let's do it. I'm gonna just keep trying until you say no. I want to go back to the lung. Wait, so a little back to me. Here we go. This is what I was trying to show you. This is my favorite operation. Share screen. So this is a lobectomy on a little baby, probably 6-month-old baby who has a lung lesion. If you don't take it out, it gets chronically infected and can have cancer in it. So here's the junction between the left upper and lower lobes of the lung. This is a little 3mm wide sealing device that we can seal tissue with. So now we're dissecting out the inferior pulmonary ligament. Here's the pulmonary artery. This is what I was saying earlier. We dissect around here, comes directly off the heart. So if we get into that, there's gonna be a lot of blood coming out real fast. We dissect this out. And then we actually use a sealing device to seal the vessel. We've sealed the vessel off here. Now we're dissecting out the bronchus. So the bronchus carries air. So you can see we're dissecting, we're getting around it here. And then we're eventually going to bring in a surgical stapler that has these teeny little titanium staples and staple off the bronchus. Before we do that, do some more dissecting. Here's the pulmonary vein right here. It takes blood back from the lung to the heart. And then we have the bronchus there. So this is getting around the bronchus. Now we have the stapler in. This is the smallest stapler that people have designed for surgery, 5mm stapler. We clamp it down, we staple across. You can see a staple there. Now the bronchus is taken out. I saw one of my partners do the same operation a little bit ago today. There's another staple load on the bronchus. And here's the lung that stays in. And then here's one more staple load on the pulmonary vein. And then we're going to be free. Now the lobe is free. Actually, no, there's the vein right there. That was one more bronchial block. Here's the last one. So here's the pulmonary vein going down to the heart. Staple load right there. Now we put a grasper below it because if the stapler doesn't work, all the blood from the heart's going to spray out everywhere. And so we want to have control over it so the patient doesn't have a problem. We staple it, and now our lobe is completely released, and we just have to take it out. Great, we have a few more minutes, we can show something else. All right, how do we get an appendectomy? That's a nice straightforward operation. So here's our appendectomy. Anybody have their appendix out? Not me, but I'm sure somebody here has. Okay, so here's the appendectomy. You guys see it moving?
Yep.
Perfect, perfect, okay. So now we're gonna put some ports in here. So here's one trocar going in. This is right above the bladder. So we put these 5mm laparoscopic ports inside. And then we go down, look in the pelvis. There's some cloudy fluid in the pelvis. Ooh, it's a no bueno situation for cloudy fluid in the pelvis. And then we go look at the cecum here. It's the beginning of the large intestine, and the appendix is attached right here. So now we go gently free it up. It's got a lot of attachments between the appendix and other structures because it's a badly infected appendix. So here we see this appendix right there. It's big, it's juicy, it's kind of gray, it's got this exudate on it. So we're going to use our electrocautery to take down the blood supply of the appendix here. So this is taking down the mesoappendix. Appendix is up here. This is taking down the blood supply. We'll burn for a little bit here. Right underneath where we're working is the iliac artery. So the blood supply of the leg is right there. So you got to think in 3 dimensions when you're doing this operation. You see it in 2 dimensions like we're seeing here, but you have to think in 3 because if the resident goes down too deep here, we could easily injure the iliac artery or the ureter, which is right underneath us. So now we get to the base of the appendix. It's actually very normal looking. We'll get there, and then we will staple across the base here.
So Dr. Gray, we have a question in the chat regarding the staples. Do the staples dissolve or are they there permanently?
That's a great question. So there are a couple different types of staplers. This type of stapler is permanent. So the staples are permanent and they're titanium staples. So if you were to go through a metal detector, they don't go off. You will see them on an X-ray or a CT scan. And then if somebody has a metal allergy, they're usually okay to have the titanium staples. There's one specific type of stapler, that was just removing the appendix. There's one specific type of stapler that has absorbable staples, and that is one that we use for fetal surgery. So if we're going to go in and open a uterus, take a baby out, do an operation, put the baby back in, we use a dissolvable stapler, which actually will allow us to staple. We stitch the 2 stapled ends back together, and then the uterus can heal, and you don't have metal staples on the uterus. So the woman can get pregnant again down the road and have a functioning uterus. So that's a good question. Yes, we do have some dissolvable ones, but only for very special circumstances. Here's a question. Are all surgeries recorded? So no. So if I want to record an operation, I have to specifically think about recording the operation. So we have a camera, we have all the equipment there. For me, I like to take pictures and give it to the family, so I'll take a lot of pictures. I can also do a real-time recording of the operation, but then I have to grab it and get on my iMovie to make these little videos. So it takes a little bit of effort, but it's not too onerous to do it. We could show a couple more videos, or somebody could ask more questions if you guys want.
Yeah, does anybody have any final questions that they'd like to ask? Now's your chance.
There were some questions about research in the chat about, did you do research in undergrad? And then what type of research do you have in your background? And did you do it during residency?
That's a great question. So I did like a summer of research in undergrad where I worked for an ophthalmologist that I knew, and he had just like some clinical research projects for me. So that was helpful, I think, just to say, okay, I've had some research experience for med schools. I also did some clinical work with them where I actually worked with patients in their office. So I was able to show, hey, I've worked in a medical environment before. Doing research, especially the basic science research, is not something that is required. A lot of people do it because there are opportunities and it's an easy way to get some exposure into medicine. And you might be able to find somebody that then lets you shadow with them. So if I have a student comes in who does research with me doing my clinical research stuff, then I'll let them shadow with me, and they come to the OR, they go to clinic, and they get to see that side of it as well. So that's, I think, pretty fun for the student to get involved. So you can get those advantages out of research, but you don't have to do it. Just making sure you get some kind of exposure to medicine and healthcare is essential. And I think that if you don't have any exposure, then medical schools might wonder if you really know what you're getting into.
Wonderful. All right, our last question is there final advice that you'd like to give to the next generation of healthcare professionals?
Oh my gosh, just have fun doing it. Just take every step along the way as its own adventure and journey. There's no like bright light at the end of the tunnel where you kind of get to the end and you're done. You know, you always keep going, you're always learning, you're always moving ahead, doing different things. And so you just got to enjoy yourself along the way. But if you want to do it, don't let anybody tell you can't. That's another thing too, is like people try to dissuade you. If you decide you really want to be, a pediatric cardiac neurosurgeon person, go do it. Don't let anybody dissuade you. You just got to work hard at it.
Amazing. Well, Dr. Gray, thank you so much for joining us today. It was an absolute honor to see all of these videos, to learn, from your insight. And so thank you so much again for joining us. We are really, really excited to have this opportunity to hear from you. So students, if you guys, there's a bunch of thank yous in the chat. If you guys have any additional questions, feel free to reach out to the pre-health shadowing team. Additionally, for my students, if you are interested in getting a certificate that verifies your virtual shadowing hours with pre-health shadowing today, stick around. I'll be going over that in this presentation. But before that, let's reflect. Here are just a few thought-provoking questions to get your brain juices flowing. We really want you to take something away from these virtual shadowing sessions. Our goal is that you are utilizing this as a way to gain exposure to the healthcare field as best as possible through the ongoing COVID-19 pandemic. And so this is something that will be helpful as you are writing your essays for medical school, nursing school, PA school, wherever you are looking to go to. So kind of keep these in mind. Of course, these are 100% for yourself. You do not have to share this with us, but if you are interested in getting published on the official pre-health shadowing website, you can send in your pieces to prehealthshadowing.com/blog submissions. We are taking reflections, reviews, success stories, and articles from today's virtual shadowing session. So if you are interested, this is great for your resume, CV, applications, as well as your LinkedIn profile. So definitely check that out. Again, I've mentioned this multiple times today, but you are interested in being a part of the pre-health shadowing team. Now is a wonderful time because we are actively recruiting for the summer and fall of the academic year. So if you are interested, definitely check out the website. Myself and a couple of our team members will be sticking around after the virtual shadowing session today for a couple extra minutes. If you have any questions about joining the team, so look into that. Additionally, this is 100% free program for all students that are interested in going into healthcare. If you want to support our mission of fighting inequity in health education and promoting diversity in the various healthcare fields, I encourage you to send this donation link to your family, friends, and community so that we can continue providing accessible opportunities for students everywhere. Now, the moment we've all been waiting for, earning your digital certificate today. So if you attended and you were participating actively, taking notes, you should be able to do well on the post-shadowing assessment. You can go to the website www.prehealthshadowing.com. You can find Dr. Gray's profile page on our website and take the quiz. You will have 2 chances to pass with 70% or higher in 30 minutes. And if you do that, then you've succeeded and you can earn your virtual shadowing certificate that verifies your hours today. It'll include your name, our professional's name, and the date of completion. You can utilize this for future applications or just to keep track of it on your end. If you missed any part of the session today, you can visit our website and YouTube channel, Pre-Health Shadowing, to watch any of our previous sessions for free, including this one. So definitely check it out. We are 100% accessible, free, open to students, and we want you to be successful in your careers. Be sure to catch our shadowing sessions every week. Check them out on our website. Sign up for the email, prehealthshadowing.com. And that is it for today. So big shout out again to Dr. Gray and all of the students for joining us today. Thank you so much again. And if anyone is interested or has any additional questions about pre-health shadowing, feel free to stick around. If not, that is the end of the shadowing session today. Thank you, everybody. Thanks, Dr. Gray.
Thanks, everybody. Thanks to Nina.